Assalamualaikum dear doctors. In this video I am discussing about the nephrotic syndrome history. So nephrotic syndrome history, the case is how come Ahmed is 8 years old, referred by the GP as he developed for 4 days mild puffy eyelids and 2 plus protein in his urine. He had nephrotic syndrome diagnosed 2 years ago, treated with prednisolone. Now, what are the differential diagnosis of puffiness and swelling as general? So that is allergy, nephritis, hypoalbuminemia, liver disease and congestive heart failure. Degree of puffiness in known case of nephrotic syndrome. If it is known case of nephrotic syndrome, what can be the diagnosis? It can be relapse case, steroid resistant case and steroid dependent case. Now, problem face the patient in nephrotic syndrome. What are the problem nephrotic syndrome patient face? Number one is hypovolemia. So, a hypovolemia, the presentation is abdominal pain. There is decrease the urine output. Remember, and shock. So, urine output is too much decrease. Hypoalbuminemia. Now, number two is infections of nephrotic syndrome problem. Infections how presents due to urinary loss of immunoglobulin and complement or steroid treatment. Patient should take prophylactic penicillin plus pneumococcal and influenza vaccines. Nephrotic syndrome patient take which vaccine? Pneumococcal and influenza vaccine. Number 3, nephrotic syndrome patient with chicken pox and measles. Steroid patient should be treatment by acyclovir, avoid vaccine. Number 4 is thrombosis. So thrombosis patient in nephrotic syndrome. Why? Because due to increase the viscosity of blood plus loss of antithrombin 3. And number 5 is steroid side effects. So nephrotic syndrome patient can develop steroid side effects. What are the steroid side effects? We know some features, that is like moon face, that is any stria on the body, and arthritis develop, and in fragile bone, wound healing is late, and there is pad on the back of the hump, that is we call buffalo hump. Now, what to ask in nephrotic syndrome? First, we know introduction is similar, and then next is we analyzing the chief complaints. History of present illness, number 1 point. Puffiness of face. Puffiness of face, the problem, what question we ask? Is the swelling for whole the face or specifically around the eyes? Any part of the body is swelling. Is it painful? Is it gradually or sudden? You notice any variation in swelling during the day? Is he complain of any allergic conditions or any associated itching? Anything make it better or make it worse? When presents first concern that might be relapse, what about protein in urine, we ask. Urinary symptoms, any concern regarding his urine. So what are the urinary symptoms, you ask? Urinary symptoms, these are amount of the urine, frequency of the urine, color of the urine. Is he feel burning sensation when passed urine, and odor of the urine. GIT symptoms of nephrotic syndrome. What we ask? The abdominal pain. Is it severe? Where exactly the site? Is it radiate anywhere? So abdominal pain, and also ask anything make it worse or make it better. Is it related to food? Then is it associated with vomiting? How many times per day, and color of the vomiting? What about bowel habits? What about appetite? Is it associated with increase in tummy size? So these are the GIT symptoms. Abdominal pain we ask. Then systemic review, one by one we ask the respiratory systems, is that any cough, difficulty of breathing or chest pain. CVS we ask any increase in the heartbeat. CNS we ask any alteration in conscious level, any headache or abnormal movement, any concern regarding his visions or hearing, that is Alport syndrome. Remember Alport syndrome also renal system features, there is hearing problem is one of the presenting features, and family history also present. Musculoskeletal system we ask any skin spots and joint pain. Past history. What are the past history? We ask when, where, by whom, how, present. So when it was first diagnosis, where and which team treatment, where he was admitted. So need admission or not. To the ward or ICU. Where he admitted, we ask. How diagnosed? What investigation done for him? Any sample of kidney taken? Follow-up. So follow-up we ask, is he in regular follow-up with whom? Nephrologist, pediatrician or dietitian? What they did in follow-up? Is he in follow-up of his weight and height? You remember maximum weight. Are you check urine for protein by dipstick? Drug history, we ask that what is the treatment? For how long? What is the dose? Side effects, respond to the treatment effect. After how many days remission achieved? Past history will ask of similar conditions, that is puffiness of the face, relapse how many times? How many times per year? History of high blood pressure, renal impairment, blood in the urine, we ask. Any past history of hypovolemia, infection, blood clots, thrombosis and complication, we ask. Past history of recurrent admission due to frequent relapse. Past history of other illness in the past. History of chickenpox, we ask. Past history of blood transfusion or surgical operation, we ask. Number 4 is nutritional history. So in nephrotic syndrome nutritional history, what we ask? What type of food? Is he in special type of food? Any restriction of the fluid and salt? Any allergy to any type of food? Any dietitian involved? Number 5, growth history. Any loss of weight? Number 6, allergies history. Bee sting can cause nephrotic. Any history of allergy? So allergy history is important because of bee sting. Bee sting also causes puffiness, like allergic reactions occur. Number 7, parental history. Any concern regarding his pregnancy, delivery or after delivery. Number 8 is vaccination history. Is he vaccinated up to date? Any extra vaccine like pneumococcal, chickenpox, influenza vaccine taken or not, we ask. Number 9 is developmental history. Any concern regarding his development. Number 10 is family history. What are the ask in family history, that is of similar conditions of kidney disease or SLE. Is your husband is your relative, degree of relative, how many children you have. 11 is social history. Social history is personal history, economic history, environmental, impact of the disease on family and impact of the disease on patient, schooling, peers, we ask. What is your biggest story? Frequent relapsing. So biggest we will ask. So this is the history of the nephrotic syndrome, we ask. Now discussion. So what is nephrotic syndrome? Triad of nephrotic syndrome, you all know that. That is proteinuria. Early morning protein creatinine ratio is more than 200 milligram per millimole. Edema, hypoalbuminemia less than 25 gram per liter. Causes of nephrotic syndrome. What are the causes of nephrotic syndrome? Primary causes idiopathic and the secondary causes are infection, that is hepatitis B, Guillain-Barré syndrome, tuberculosis and malaria, systemic lupus erythematosus, Xenoscoline purpura and bee sting. So bee sting, all the cause of nephrotic syndrome. Important definitions in nephrotic syndrome. These are: fast remission. What is remissions? That is negative urine analysis on fast morning urine for the 3 consecutive morning. That is remissions. Relapse. What is relapse? Common 2 to 3 of cases, 2 plus or more proteinuria on dipstick on 3 consecutive days, fast morning urines. Frequent relapsing is that 2 or more relapse within 6 months of diagnosis or 4 or more per year. Now what is steroid sensitive? Steroid sensitive is that response to the steroids in the first 4 weeks of the treatment, that is diuresis, disappearance of the edema, negative proteinuria in 3 urine samples taken at night. Steroid resistant. What is steroid resistant? That is proteinuria persists after the 4 week of treatment. So if proteinuria persists after the 4 week of treatment, that we call steroid resistant. Steroid tolerant. So steroid tolerant, how can ask? Patient with complications such as hypertension, increased weight, cataract and embolism. That is steroid tolerance. The side effects we will ask. Steroid dependent, that is proteinuria appears when the dose of corticosteroid is decreased, alternate dose or relapse within the first 2 weeks after treatment is stopped. Then the management plan. Discussing the management plan of the nephrotic syndrome. First is admissions. Then we do the investigation. Number 2. Investigation are urine dipstick, culture sensitivity, early morning protein, creatinine ratio and urinary sodium. Blood for what we do? CBC, urea and electrolytes, albumin, cholesterol. C3, that is reduced C3 is atypical features and C4. Varicella zoster titers, hepatitis B and C serology. Anti-ASO titer can be useful. Autoimmunoprofile in atypical features, ANA, anti-double standard and DNA. Number 3, management. We involve the multidisciplinary team. General measures we take in the dietitian involvement for low salt diet. Monitor and cannot control the fluid balance by input-output chart and daily weight. Check his blood pressures. Need referral if more than 95 centile. Parent education. What are the parent education we give? Aware of the complication, in particular if develop abdominal pain. Aware of steroid side effects. Urine dipped daily till remission, then twice weekly while on tapering dose or child is unwell at any time. Drug treatment. What is the drug treatment we give? Steroid treatment, immunosuppression treatment, renal biopsy and referral to the nephrologist in steroid resistance. ACEI for proteinuria and blood pressure and penicillin prophylaxis. Management of the complications, see down. Okay, so management of complication also we do. Number 1, steroid treatment. So number 1, in case of steroid sensitive, which is 90% are steroid sensitive. Then prednisolone 60 mg per meter square for 4 weeks. Then 40 mg per meter square on alternative days for 4 weeks, then stop or continue 30, 20, 10 and finally 5 mg per meter square 4 weeks each alternate days. Number 2 is in relapsed case. Prednisolone 60 mg per meter square till remission, then 40 mg per meter square on alternative days for 3 doses and reduce the alternate days by 10 mg per meter square every 3 doses and finally 5 mg per meter square on alternative days for 3 doses, then stop. Number B, immunosuppression drugs. So in case of steroid dependent for frequent relapsing. When steroid dependent but frequent relapsing, what we give? Cyclophosphamide, dose is 2 mg per kg for 12 weeks. Side effects: hair thinning, bone marrow suppression. Tacrolimus we give, and tacrolimus causes nephrotoxicity side effects. Cyclosporin. Cyclosporin dose is that twice daily for 12 to 18 months, and side effects is hirsutism, gum hyperplasia, and nephrotoxicity. Mycophenolate, that is Calcept tablets. What it causes side effects, GIT intolerance and no nephrotoxicity. Number C, renal biopsy. When renal biopsy plus refer to the nephrologist in case of steroid resistance. So when steroid resistant, we do biopsy and refer the nephrologist. Commonest treatment in resistant cases. What are the commonest treatment of resistant steroid? Alternate day prednisolone combined with the cyclosporin, ACE inhibitor and or angiotensin 2 receptor blocker for hypertension and proteinuria. Renal transplantation can be considered. I am telling what are the complications of the nephrotic syndrome. These are complication of disease. Number 1 is hypovolemia can develop. Hypovolemia presentation is that abdominal pain, tachycardia, increased capillary fill time, wide core peripheral temperature gap, increased PCB, decreased urine output. This how to check for hypoalbuminemia in edematous child. So edematous child but hypoalbuminemia. These are the features. Remember, abdominal pain, tachypnea, increased capillary fill time, wide core peripheral temperature gap, increased PCB, decreased urine output. Next, number 2 is infection, one of the important complication of nephrotic syndrome. Infection, what is? That is increased risk of infection due to urinary loss of microalbumin and complement and steroid uses. Prone to pneumococcal, Haemophilus influenza infections, especially peritonitis and septicemia. Prophylactic penicillin plus pneumococcal and influenza vaccine. Prone also to chickenpox treated by acyclovir and varicella zoster immunoglobulin and measles. Number 3 is thrombosis. Thrombosis is due to loss of antithrombin 3 and hyperviscous blood, prevented by hydration and encourage the mobilizations. Number B, complication of treatment. What are the complication of treatment develop? That is number 1, diabetes mellitus and hypertension. 2, osteoporosis. 3, reduce the growth in children. 4 is gastritis and peptic ulcer disease. 5 is glaucoma or cataract. 6 is acne or skin bruises. 7 is delay on healing, and 8 is increased risk of infection. So these are the complication of treatment. Next, what is possible cause of abdominal pain in nephrotic syndrome? So is the patient complain nephrotic syndrome that abdominal pain? What are the possible cause in our mind come? Number 1, hypovolemia due to splenic ischemia. Number 2, renal vein thrombosis. Number 3, peritonitis, and number 4, gastritis and peptic ulceration in case of prednisolone tablets. When you refer to nephrologist, if there are any atypical features, when we refer nephrologist, now these are number 1, age is less than 1 year and more than 12 years. Number 2, renal impairment. Number 3, persistent hypertension. Number 4, gross hematuria. 6, steroid resistant. 7, steroid dependent. 8, frequent relapse. And 9, systemic features of vasculitis such as rash and arthropathy. 9 is that family history of systemic illness. And number 10 is acute complications such as severe hypovolemia, infection or thrombosis. So this is all about the full history and discussions of the nephrotic syndrome. Please do subscribe and share. MRCPCH with Dr. Amma Chaudhuri. And of course, notice on the comment section, I always update information. Thank you.